Hello, good afternoon and welcome to today's suicide prevention webinar. Thank you for joining us. This is the final webinar in this series and we're very pleased today to welcome Professor Rory O'Connor from Glasgow University. Sorry, I've just had a sign coming up saying my Wi-Fi is bad, so I hope that it sees me through this bit. Who's going to talk about understanding the transition from suicidal thoughts to suicide attempts and the role of safety planning. And we're welcoming back Linda Thompson, who is peer support worker with Oxford Crisis and Home Resolution team, and she has been on a couple of webinars previously. Now, before I hand over to Rory, you may remember from the first webinar, I talked about the forthcoming changes to the care notes risk assessment tab, and these are going to go live from the 7th of December. So this is a change to our risk assessment tab in that the current box that says a risk summary and is blank will change to become a risk formulation box, and there is an addition of a safety plan component to that tab, so you can upload safety plans that you've completed in collaboration with your patients and wherever possible carers or family members. So the current facility in care plans for the safety plan will cease to function from the 7th of December for new care plans, and new risk assessments will have these new capacities. There will be some comms nearer the time, but it was just really to update you today. Thanks very much, and I will now hand over to Rory. Thanks, Rory.
Yeah, I'm unmuted. Great. Thanks, Karen, and thanks, Katerina, in advance for navigating the slides. So over the next 20 to 30 minutes, what Karen has asked me to do is talk about some of the work we've been doing in terms of safety planning, but I think what I'm going to do is do that in a couple of ways. One is contextualize that within a theoretical model of suicide that I've developed, which just helps us understand, first of all, the emergence of suicidal thoughts, but then crucially, the transition from thoughts to acts or suicidal acts. And then that sets a scene nicely for developing or delivering safety planning, because to my mind, safety planning primarily is around that transition. So I was really trying to understand that better. So next slide, please, Katerina. So the way, as I say, I'll do that is I'll put it in the context of this model of suicide, the IMV model, or the Integrated Motivational Volitional Model, which I developed a few years ago. So I'll describe the model in detail for the context of setting the scene for today. And then, as I said at the outset, focusing on what I describe as sort of crossing the precipice from suicidal thoughts to suicidal acts. And the best data out there suggests in sort of general population samples that of those people who think about suicide, about a third will make the transition from thinking about suicide to acting on their thoughts. So obviously from a clinical perspective, at the heart of one of the key things we're trying to understand then is, can we better understand that transition from thoughts to acts? Can we have a better sense of what are the factors to look out for which will help us better identify those who are more likely to make the transition? And of course, that's set in the context of the fact that the reality that suicide itself is still really difficult to predict, and there's we're no better than the flipping of a coin or a chance in predicting suicide. So although our ability to predict suicide is limited, that shouldn't prevent us from gaining a better understanding to inform formulation and treatment planning, so we can obviously mitigate as much risk as possible. And I suppose that's where I think safety planning comes into play. So as you can see in that third bullet, I'll focus in on what the evidence tells us so far on safety planning type interventions, and then hopefully some conclusions. Next slide, please, Katerina. Okay, so I've been working in the field of suicide research and suicide prevention for 25 plus years, and I'm a psychologist, so I'm coming from a psychological perspective. And about in 2011, whatever that was, 10 or 15 years into my sort of suicide research journey or career, I was keen to assimilate what the evidence told us or what factors seemed to be important. And that led me to publish in 2011 the Integrated Motivational Volitional Model, or the IMV model, which then I updated with my colleague Olivia Kirtley in 2018. And I suppose part of my thinking around the development of the IMV model was to look beyond psychiatric diagnoses to help us understand suicide risk. Because of course, yes, in Western countries, the overwhelming majority of people who die by suicide or attempt suicide, it happens in the context of some mental health problem. Again, the stark reality is the overwhelming majority of people with mental health problems, like, for example, depression, never ever attempt suicide and certainly will never die by suicide. And indeed, if we look at the evidence for those treated for depression, say in hospital, it's about 4% who will die by suicide. And so then really what the culmination of what led to the model was my attempt to try and have a better understanding of, just use one factor there, that 4% figure from the depression literature, is to better understand the 4%. Because crucially, if we're trying to prevent suicide, we need to understand what's similar and different from the 4% of, say, people who are depressed who die by suicide from the 96% who don't. And I think that's a challenge I think we all face. And so to my mind then, the IMV model gives us a framework to try and formulate, understand, conceptualize suicide risk, but crucially also form the basis for treatment interventions. So in a very parsimonious way, the IMV model is in 3 parts. So in the left-hand pane, or the left-hand column, is the pre-motivational phase. And the pre-motivational phase, in essence, is just a background context or the biosocial context in which suicidal risk may emerge. So in a way, that left-hand side is probably just the start of a clinical history. We're trying to look at people's vulnerability factors in terms of diatheses. We're looking at environmental influences. For example, we know that obviously if you look at the inequality gradient associated with suicide, you're at least 3 times more likely to die by suicide if you're from a disadvantaged background compared to a more affluent background. And then the third one is negative life events. And that idea, we know again that the trauma, or the proportion of or the frequency of trauma at all stages in life, early life, in terms of early life adversity, as well as throughout the lifespan, is significantly more common in people who had died by suicide than those who we compare them to in terms of controls or comparisons. But in essence, that's just the context that we're trying to understand somebody's life history or somebody's story. Then if we go to the second and third phase, this is where, in terms of understanding suicide risk, I think is particularly important. So if the left hand, so just so I know, when I use my cursor, can anybody see it? Or is it just me? I'm getting very excited with my cursor, but nobody else is getting the benefit of that. Okay, so on the left hand side, if the pre-motivational phase, one word to describe that would be background. But then if we move on to the motivational phase, which is that central portion, one word to describe that would be ideation. And what we're trying to do is understand the emergence of suicidal thinking. And then on the right-hand phase in peach, the volitional phase, the third bit is understanding action. So going from understanding the transition from thoughts to suicide attempts or death by suicide. And so according to my thinking, and building on work that Mark Williams did over many years at Oxford and other colleagues, the argument here is that suicidal thinking, so suicidal thoughts, suicidal ideation or intent, emerges when individuals feel trapped by mental pain which is often driven by feelings of defeat and or humiliation. And that those feelings of defeat and humiliation are often also triggered by shame, rejection, and loss. So to my mind, if we're to understand suicide risk, what we're trying to understand is what are the drivers to that sense of entrapment? What are the drivers to that mental pain? And that mental pain can be driven internally or externally. So internal entrapment would be characterized by those unbearable thoughts that an individual struggles to control, about feeling a burden on others, feeling a loss to loved ones, feeling that they're a burden on their loved ones, and that ultimately that people would be better off if they were dead. But it also can be driven by external factors, that external entrapment, which is obviously trapped by life circumstances, and that could be relationship crises, lack of employment, or whatever, and often they're interrelated. But from all the work that we've done and others have done, internal entrapment is much more powerful, much more pernicious than external entrapment. Now, so also you'll see lower down that model in that middle phase is there's a range of other psychological factors and processes which help us understand the movement, say, from feelings of defeat to feelings of entrapment to feelings of suicidal thoughts. But that's beyond the scope of today. And if people want to know more about our work and about the IMV model, you can go to our website, which is suicideresearch.info. All of the published material I'll talk about today is available on our website, including podcasts and all our papers. And then in addition, I also this year published a book, When It Is Darkest, Why People Die by Suicide and What We Can Do to Prevent It. And it's really the culmination of my thinking over the last 25 years. And it's written for a general audience, for individuals who've been personally bereaved by suicide, people who've been suicidal themselves, as well as clinicians and others working with those who are struggling or who are suicidal. And it tries to bring to life, in a sense, people's own stories, both of bereavement as well as recovery, of people I've met on my journey thus far. And then the third bit of the model, just to return to the model, is the volitional phase. And the volitional phase I'll return to in a couple of slides' time, because to my mind, what we're trying to do is when somebody becomes suicidal, we're then trying to do two things. One is, can we alleviate their suicidal thoughts, right? That's one thing we want to target as a treatment target. Or if we can't alleviate one's suicidal thoughts, what can we do to keep an individual safe so they don't cross that precipice to suicidal behavior? And to my mind, that's when the volitional phase, and as you'll see in a second, 8 key factors come into play. So then, just to summarize then thus far, according to the IMV model, part of the final common pathway is feelings of defeat and humiliation that one feels trapped by. That sense of entrapment is key. But the factors that lead somebody to act on their thoughts of suicide are different from the factors that lead somebody to become suicidal in the first place. So that sense of that sense of burdensomeness, which leads to entrapment, is key to the emergence of suicidal thoughts. But they're the motivational phase factors. But then the third bit, which I'll return to, are these volitional phase factors, and they're key to that transition. So the factors that govern the transition from thoughts to attempts are different from the factors that lead somebody to be suicidal in the first place. So before I move on to the volitional phase, just next slide, please. I want to just say something about how we assess entrapment, because I would argue that we should be routinely monitoring entrapment in treatment sessions. Entrapment and sorry, hit again. So the thing come up. Yeah. So over the years, we've used Paul Gilbert's 16-item measure of entrapment, which taps both internal and external entrapment. But last year we published a brief version of it, a 4-item version, which is pretty strongly correlated with the 16-item version. It's 0.94 in a clinical sample and 0.97 in a non-clinical sample. And these are the 4 questions we use. So I'd encourage people to think about using these questions to monitor entrapment as a proxy measure for the emergence of suicidal thoughts. Because again, we've published a number of studies now which highlight that basically that entrapment is a key bridge between feelings of defeat and suicidal thinking, and that people's scores on this entrapment scale do statistically predict repeat suicidal behaviour prospectively. So I would argue, make a case for entrapment and the driver for entrapment being a key treatment target to understanding suicidal risk. Okay, I want to now just pop on to the next slide, which is returning to the focus of today, is understanding that transition. Now, this is a heartbreaking quote from a mother I met a few years ago, whose son died by suicide. And as somebody who's been twice bereaved by suicide myself, and I talk about this in the book, what we're trying to do is better understand that who is more likely to cross the precipice. And this quote here, this is worth reading aloud. I never thought he'd do it. A few weeks before his death, he had told me that he had thoughts about being dead, but I was too scared to ask him directly whether he would kill himself. I haven't stopped asking myself why I didn't ask him. Not a day passes when I don't torment myself with this question. When I look back on it now, I just didn't think he was the type of person who would kill himself. I know how ridiculous that sounds, but he was always just full of life. And I just think that, to my mind, that conversation really stuck with me, partly because, well, for many reasons, but partly because it speaks to this idea that people think there's a type of person who will die by suicide, and that there's a particular face of somebody who's suicidal, whatever that means, because there's not. But crucially, in the IMV model and my volitional phase stuff, is my attempt to help us better identify that transition. And so next, if I move to the next slide, please. The next slide is basically, if you think back to my model, the third part of my model on the right-hand bit is the volitional phase. And all I've done here is blown that up in a way which makes it easier to comprehend. So in the blue on the left-hand bit, you see the left-hand panel, you can see suicidal ideation or intent. And then in the peach on the right-hand side, you get suicidal behavior. And then the argument then is that those 8 factors in the middle, the presence of those volitional phase factors, basically increase the likelihood that someone will act on their thoughts of suicide. And again, many of them will be no surprises to us. And what I tried to do when I revised with Olivia the model in 2018 was make this more explicit. So again, we know from the suicide research field that people who think about suicide and have access to the means of suicide, unsurprisingly, are more likely to act on their thoughts. The greater extent to somebody plans a suicide attempt, more likely to act on their thoughts. And indeed, that's at the heart of safety planning. But then if you look at the third one there, exposure, one of the things, I would say one of the most stark findings we've found repeatedly now over probably the last 10 or 15 years in particular, has been the powerful effects of exposure. Knowing somebody else, having a family member or a close friend who's attempted suicide or died by suicide, increases the that will act on our thoughts of suicide. Impulsivity is next. Again, no surprises. The more impulsive somebody is, the more likely they are to act on their thoughts. And then the next two, physical pain sensitivity or tolerance and fearlessness about death, often are put together and described as the capability for suicide. And building on work that Thomas Joyner in the United States has done is trying to, the argument being that people who die by suicide or make suicide attempts have higher physical pain tolerance, which is often required to carry out a highly lethal suicidal act, and they have to overcome the life instinct in terms of fearlessness about dying and death. And then the penultimate volitional phase factor is mental imagery. So individuals who have thoughts of suicide and have pictured themselves dying or dead are more likely to act on their thoughts of suicide. And again, we think that's a process of habituation, or also could people who, in terms of mental imagery, you're basically role playing in your head or what might happen, and then it obviously can also lead to you can then think through barriers and so on. So it's, again, evidence would be that mental imagery is an important risk factor. And then the last one is unsurprising, that the single best predictor of any future behaviour is past behaviour. So if somebody is engaged in suicidal behaviour or any form of self-harm in the past, they're statistically more likely to do so in the future. So that's at the heart of the framework in which we're going to then move on to the safety planning in a second. So these 8 key factors are at the heart of understanding that transition. And we've published a number of studies now, and other groups have, which demonstrate when you do multivariate analysis that these 8 volitional phase factors are at the heart. They differentiate people who think about suicide from those who attempt suicide. And they've also been shown to predict suicidal behavior over time. And again, what I've tried to do with this slide is give questions on how we might try and tackle those in a clinical context. We're trying to understand the presence of these. Of course, some of them, like the physical pain tolerance, obviously that is not going to be possible to do in a clinical context. We do experimental based work. We try and assess people's physical pain tolerance in the lab, but that's us trying to disentangle the mechanisms which increase risk or decrease risk. Next slide, please. So this is just one of the studies we did. I've got one study of that, and then 2 slides in this, and then move on to then the safety planning stuff. So it's just an example of one study we did with a nationally representative sample of young adults, and we're able to then identify a group of people who thought about suicide, the ideation group, group of people who had attempted suicide, and then we've assessed basically the motivational phase factors like defeat and entrapment, and the volitional phase factors as I've just outlined. And if you look at the next slide, and you might have to repeatedly hit this one, Katerina, because it's an animation one, so just keep going, keep going. And one more. Perfect. And but what's of note here is if we look at the motivational phase factors, when you do the multivariate analysis, they're not differentiating people who think about suicide from those who attempt. It's not the people who are more trapped are more likely to attempt suicide. That's not the key driver in a multivariate model. But where we start to see the differences are people that attempt suicide are more impulsive, have higher levels of this capability for suicide, higher levels of mental imagery, and we're more likely to have a friend who'd attempted suicide. Now, we were surprised that there was no differences in the last 2, but we think that reflects the fact that this is a young adult sample and that your influence of your peers and friends is more powerful as a young adult, perhaps, than the influence of your family members. Okay, so that was just an example of one. And the last, I'm going to go on to have 10 more minutes to go, is basically, if we move on to the next slide, please. So that's the context. And I want to now finish with us focusing in on interrupting the transition, because ultimately that's what we're trying to do. If I can't prevent somebody becoming suicidal, what can I do to interrupt the transition from thoughts to acts? And next slide, please. A couple of years ago, with Gustavo Turecki and colleagues, we published a review paper which summarized the evidence of what works in terms of interventions. And the good news has been that in the last 15 years, there has been a growth in psychosocial interventions, and mainly psychosocial interventions, less so for pharmacological interventions. But there's been a increasing evidence base for each of these listed here. Now, there's been particular interest in safety planning. That's what we focus on in a second with the evidence. I focus on safety planning in part because we know from some of the trials over the years is often people who've attempted suicide, their ongoing engagement in standard treatment trials is challenging, and that should be a reason not to continue to try. But there's been this idea of trying to add on adjunct interventions, in this case brief interventions, often when an individual is in crisis, so that even if we don't see the person again, that there's taken something away with them which hopefully can mitigate some of the risk. And a lot of that interest has been on safety planning in the last few years. Next slide, please. And indeed, a meta-analysis which is published, I think this was published in 2020, I just realized there's no year in that. But this was looking beyond safety planning. It was looking at suicide attempt interventions, effectively crisis interventions in acute settings. And what was pretty clear from that meta-analysis was that there's clear evidence that these sort of psychological, psychosocial interventions were effective. Now, if we move on to the next slide, what that didn't tell us though was the active role of whether safety planning itself was effective. And so if we then look at the safety planning literature itself, this is probably the seminal paper on safety planning to date. It's not an RCT, it's a case cohort, a cohort comparison study that Barbara Stanley and Greg Brown, who obviously are the architects of safety planning, published in 2018. Now this is with military veterans, but the key finding is clear. There's a 45% reduction in future suicidal behaviours. But the thing is not just safety planning, it's safety planning plus telephone support. But it's given us more promising evidence of the clinical effectiveness of safety planning. Next slide, please. So earlier this year, along with colleagues in the Netherlands, we published a meta-analysis trying to summarise the evidence base for what we described as safety planning type interventions. So more focused than the previous meta-analysis from the United States I touched on 2 slides ago, but it still is this studies which, even though we call them safety planning type interventions, they often had other components as well. But nonetheless, what was clear again was, in terms of the meta-analysis, there was clear evidence that safety planning was associated with protection, with reduced suicidal behaviours over time. And indeed, if we go on to the next slide, we've conducted a feasibility study in Scotland, looking at, and head again, please. A feasibility study in which we're trying to see, well, can we implement safety planning and test it in a UK NHS context, but again, not just in an NHS, not just safety planning on its own. In our study, on our feasibility study, what we found, and I'll give you some findings from that in a second, we administered a safety plan within 24 hours of a suicide attempt in crisis in hospital, and then individuals were offered 4 to 5 weeks of telephone support, weekly telephone crisis support in that period, and that immediate period following discharge from hospital, which is obviously so important because it's such a risky time. But before I give you a slide on that, obviously it's worth remembering and reminding ourselves, obviously, of what a safety plan is and what it's not. So you can see from that left-hand picture, obviously what a safety plan is 6 steps, 6 basic steps. If we just move on to the next slide, please. Oh, sorry, yeah, oh, sorry, and oh, sorry. The other thing before we move on to that next slide, though, so is what's absolutely fundamental and important about what popped up in that last slide is that certainly when we've been using the safety plan and when we did the training with Barbara and Greg in the sort of gold standard administration is a recognition that obviously the intervention is so much more important than that form, and it's that collaboration, sense of compassion, and that connectedness is at the heart, we think, of why a safety plan is effective. But the other thing worth noting is what it is and what it's not. So obviously what it is obviously a dynamic document. It shouldn't be just something written in a tablet of stone. And obviously across its 6 steps, what it simply gets people to do is identify both internal and external coping responses to distract an individual when they feel a crisis is escalating, as well as then obviously identifying both somebody they can contact in a crisis for support, as well as professional agencies, and a way of keeping the environment safe. And I'll move on to that in just a couple of minutes before we finish. But it's also worth noting about the fact that, of course, it's collaborative and it was designed initially to fill in important gaps in somebody's care or end of care, but it shouldn't be used with people with imminent risk of suicide, and it's not clear yet to what extent it is effective with people with cognitive impairment or other neurodiverse profiles yet. Next slide, please. So what we found when we did the safety plan in the Scottish context, and do you want to hit that again, Katarina, to get the key finding? What was really stark about the findings, so as I said already, is this was a feasibility study, so we can't determine efficacy. We were just looking at trying to embed it in an NHS context across 4 different hospitals. But basically, when people completed the safety plan in hospital, and then we offered weekly telephone support over the next 4 to 5 weeks. But what's worth noting is that when we did the telephone calls, 81% of participants discussed their safety plans during those 4 or 5 weeks. But crucially, 79% said that they used it, or the intervention group used it at least once since the baseline. So it gives us some sense that when we think of, although we can't say anything about efficacy, what I think it highlights quite nicely is obviously that people are using it at that moment where we think risk is greatest. Now, the last thing I'm just going to finish with, and then going to open it up to questions. And what I've got left, and I'm not going to talk through the rest of the slides. The rest of the slides are just more detail on doing a safety plan, which obviously people can the resources that's going to be available on with our intranet. So again, it gives you more detailed description on safety planning. But before I just finish, if you just go to that next slide, please, Katerina, and then I'll just bring it to an end. So the things we don't know yet is, yes, the evidence base is growing, and certainly when we look at our meta-analysis and other meta-analysis, there's definitely growing evidence for safety planning as part of other longer-term interventions. And the Barbara and Greg's work and even our feasibility study had safety planning plus telephone support. So the bit we still don't know quite yet is the extent to which a safety plan itself is interrupting suicidal thoughts. Now, we've some data from obviously our interviews and our process evaluation. When we spoke to patients after who'd taken part in the study, they seem to tell us that it is effective, but we need to do more on that. And then just the last thing before I open it up, or to Linda, I think next, is, oh no, sorry, no, back again. Sorry. It's just this last slide is, so in the book I just talked about, I have a full chapter on safety planning, which describes a lot of the slides, which follow for your reference, but also I think what we certainly learned from using it, working with people with it, and also the gold standard recommendations that Barbara and Greg say about how we should optimally integrate safety planning into clinical care. Okay, so just to finish, what I've tried to illustrate in the last 28 minutes or whatever it is to provide a context of understanding suicide risk, both in terms of the factors that lead somebody to become suicidal, and then crucially, using the IMV model, understanding what those key factors, which we might want to think about in terms of understanding who is more likely to cross the precipice from suicidal thoughts to suicidal attempts, and then end with the evidence illustrating the growing evidence now for safety planning as a brief adjunct to usual care, perhaps an extra tool in our toolkit, which can hopefully help interrupt the transition from thinking about suicide to attempting suicide. Thank you.
Thanks very much, Rory. That was really, really comprehensive and informative. So thank you. And I'm sure we'll have lots of questions coming. But before then, Linda's going to share with us sort of a couple of things, really. I mean, it'd be great to hear your perspective on Rory's presentation and how that resonates with you, but also your experiences having used services and been involved in safety planning from your own perspective, and also in your capacity as peer support worker. Thanks, Linda.
Hi, great to see you all again that I can't see. But anyway, Rory's presentation was absolutely brilliant. One of the things I picked up was, you know, that paragraph from that mother who's saying that, you know, I didn't know that he was going to commit suicide. He didn't look like it. And nobody would have known if I'd actually gone through with suicide, because I had a cupboard and my cupboard would have different masks that I'd put on my face so that nobody would know what I was feeling inside. And out of all the times that I did try to commit suicide, mine was spontaneous. You know, I had mental imagery only on a few of the times, and that was the times that sort of came out of the self-harm into the suicide, and I realized then that this is going to happen. But it didn't, fortunately for me. It didn't happen, and I was never scared of dying until the one particular episode where I had the mental imagery. The impulsivity was really, really great. Even though I might have had a life event that caused me to go into crisis, and I might have spoken to a clinician that day, when I actually got home and the thoughts were just coming furiously and fast, it wasn't a case of I thought about what I'd spoken with a clinician. It was impulsive, straight to the tablet box, and away it went. And there wasn't even a thought of contacting anybody or anything like that. So the safety planning side of it, it was always done for me and given to me at the end. Here's your safety plan, have a good read of it when you get home, and then, you know, we'll see how it goes in the next few months. Well, that went into the bin when I got home. I didn't have the capacity to sit there and read it. And then, you know, when I saw my clinician again afterwards, did you read it? Yeah, I read it. And if you know, with people like myself, you would lie. You wouldn't actually speak the truth and say, oh, yeah, I read it. No, you know, that I actually did read it. But, you know, one of the things when I went into my therapy was I was given the safety plan myself. And I sat there and I had to write it out. And I thought, what a cheek. They don't want to do it now. I'm going to have to do it. But that was when it was the most positive of a safety plan for me, because I wrote it out. I knew what I wanted. I knew what I needed. I knew who to contact, when to contact somebody, when my emotions were going to be that bad that I could look into doing something completely different or acting opposite to what I was feeling. And then moving into when I'd finished therapy and I went into being a peer support worker, one of the first things we do in the position that we're in is we have a safety plan done straight away. But as a peer support worker, if I ever do a safety plan, it's about the language, and it's about the language that you use. And because I'm a peer support worker, I think it's a bit easier, because I go to somebody and I've got all the paperwork I've got to take, and I'll say, listen, you know as much as anybody else, but we got to fill in this paperwork, and you know it's important, you know, and you know they always want it, so let's sit down, here you go, and I'll sit here and I'll help you with it. So I'm more on their level on the way of talking about it and getting them to fill out the safety plan the way I had to first fill it out, thinking that the clinicians didn't want to bother anymore. But it actually works. And I remember one particular lady I went to see, and I'd come out with this, come on, you know, we've always got to fill out paperwork. And, you know, at the very end, she actually thanked me after, because we only do a brief intervention, as everybody knows, with the crisis and home treatment team. But she actually thanked me and said that, you know, she had really worked well with me in filling out the forms and making her realise that, you know, there is a different way of looking at things rather than going down the suicide node. And I think it's question time.
Thank you, Linda. That was great to hear your various perspectives. So helpful, and I think language is it's so important, isn't it, in the context of that compassionate and collaborative relationship, and certainly language has been a theme throughout these webinars. I wanted to try and copy and paste a link to the safety planning film that Linda and I were involved in. Linda actually acted in it. And anyway, I can't work out how to copy and paste it, but we'll link it with, we'll put a link to it next to the webinar on the intranet. So do please watch it or share it with people as a training opportunity, because I think it conveys that sort of compassionate relationship very well and goes through the 6 phases of safety planning. Right, let's get to questions. So I'm going to, we've had a few. Firstly, Rory, this would be to you. Have there been any studies exploring how these factors apply in older adults, i.e. do older adults have the same factors that show a difference than those with suicidal ideation versus suicidal attempt? So this is in relation to your model.
There's been some work with older adults, but I don't know so in some of the different, so certainly some of the factors have been shown to be, but I'm unaware of any study which is just focused on so in some of our work with young adults, for example, we've looked at every single factor within the model, but I'm unaware of any studies which have just focused on all of the factors within an older population. But we do know that there's definitely studies on exposure, there's definitely studies on the planning, there's definitely studies on mental imagery across the lifespan. So, but I think that's another area for more work.
Yeah, sure. That came out last week as well, actually, more research with older adults needed. Next one I'm going to pass to you first, Linda. It's a question around resilience protective factors. Is a resilience protective factor perspective useful in practice, do you think?
I think, you know, like with myself, if I'm going out to see somebody, the protective factor is looking at doing something different. And a lot of things that I've been doing at the minute with a lot of my clients is using mentalisation. And the one that I particularly use is the one where you're thinking of colour all the time and relaxing the body when you think of colour. And whenever you get your mind into a state is to push whatever it is that's coming in all the time out and just keep having that colour in your mind the whole time. And a lot of the times I do put them onto mentalisation, take sheets out with me as well to try and find something that would work for them. You know, looking at some of the different models as well that have come out to use that as well, what your particular feelings are, what are your feelings when you're starting to feel the actual urge to do something, and how can we change those feelings? How can they find something to change it? Whether it would be, you know, distraction techniques, or whether it would be using something that would look like blood or look like tablets to take. I remember at one point I was told to cut out vegetables in the shape of tablets and actually take them and chew them. So it was a complete doing the opposite, or using something that is, you know, a little bit more resilient than throwing tablets down your mouth or cutting yourself.
Thanks, Linda. Rory, do you have any thoughts to add?
I mean, I suppose it depends what we mean by resilience protective factor, in that obviously if we look at the evidence for, say, something like self-compassion, which arguably is a protective factor. There's evidence, of course, that it protects against suicidal thoughts and self-harm. So I think embedding that obviously in a treatment response, obviously in a strengths-based type approach is obviously really important. And then if we look obviously at social networks and social support, I mean, so there's lots of different ways in which one could conceptualize that. In terms of resilience itself, I mean, I always struggle with what actually resilience means as a term. I obviously know what the definition of resilience is, but to me, it's just a way in which an adaptive way of coping from stressful situations. So of course, then it's trying to then think about how can we work together to collaboratively build somebody's coping and problem solving responses. So I think there definitely is obviously stuff to be done there.
Thank you. Right, moving down, because I've just been trying to publish another couple, so I've missed, but there's one here. Are we putting too much effort into predicting if thoughts will progress to action? Should we not just assume that they could and do a collaborative plan? Rory.
Do you want me to, yeah, well, I mean, I think yes is the answer. Even with machine learning approaches, which we've done some machine learning work, and I think it has an important place, but part of that emphasis is trying to get as many factors as possible to enhance our predictive utility or whatever, or positive predictive values. And but the reality is even with all the most sophisticated techniques in the world, thankfully, although every suicide is an absolute tragedy, of course, that because the base rate is statistically low, our ability to predict with sufficient sensitivity and specificity will always remain difficult and challenging. So I think absolutely we should be going for this mitigation approach. That should be at the heart of everything we do. And I wouldn't assume it, but if we mitigate and think about what we can do, yeah, I think that's a much more useful way of formulation and treatment planning.
Yeah, and I agree. Linda, anything to add?
No, I'm in total agreement with that.
Yeah, good. And certainly that's the stance we're hoping to take in the trust. I'm surprised of the statistic of 1 in 3. I'm surprised by the statistic of 1 in 3 people who have suicidal thoughts go on to make an attempt. This is higher than I thought. A lot of clients in this service report thoughts. I think the inference there is, but less go on to act in this person's experience.
Yeah, no, it's important. Well, that stat comes from the World Mental Health Surveys, and what it doesn't. So on one level, you would think that then the actual rate of transition from thoughts to acts would be greater in people who present to clinical services, but the difference is, but they're the majority, so they're the group of people arguably who are obviously getting help and support, which hopefully will reduce their transition. To me, the issue is that a wider issue, which is that we still have less than or more than 70% of people who die by suicide are not in contact with mental health services in the 12 months before they die. That's, to me, the big question, and trying to understand that transition better and protect those people, I think, better. But yeah, I was surprised when I learned that stat first.
Okay, there's one here which I'll come to both of you with. What is the evidence of safety plans if there is ideation but no attempts? Are they as effective as they are post-attempt? So I guess from an experiential perspective, Linda, can I come to you first on that, and then we'll ask Rory what the evidence is?
Well, for me, yeah, it works, because even going into therapy, it didn't stop the suicidal ideation. It didn't stop the strong feelings that I can't cope anymore, I can't do this anymore. But having written out the safety plan myself and actually looked at it, it did stop me actually taking another overdose, because I'd written it myself and I remembered what I'd written and I could go back and look at it, rather than it going in the bin, somebody else writing it. But yeah, it did stop me, and I haven't taken another overdose for 12 years now.
Great, thank you, Linda. Rory.
But can I just say on response to Linda? Linda, you've made a really important point twice, I think, or maybe more. You've said it, you've made lots of really important points, but one which I think is so important, and it's the heart of, I think, safety planning, is it's your safety plan. I think that's so important. And you mentioned obviously writing it yourself was helped with that ownership. But certainly the work we've done, if you look at the evidence, that's not a prerequisite, but it's that sense of ownership. It is a collaboration, and I think, and genuine, I think that's so. I don't think we can make that point often enough. Then getting back to the question, I actually don't know, if I'm trying to think of the evidence base properly, I don't think we know the answer, actually, because most of the studies have either been purely people who've attempted suicide first and at a baseline, and then the safety plan has been completed, and we're trying to reduce repeat suicidal behaviour. A few of the studies, I think Barbara's studies, I think, had mixture, because they had people who, there was different inclusion criteria. But to be honest, I don't know whether we know the absolute empirical answer to that question, to be honest. Now, for me, the bit would be, and I think Linda sort of touched on this, is thinking about what would you need to do differently with completing a safety plan with somebody who hasn't previously attempted suicide. I think, because there might be, you might have some nuance, you might have the narrative, the way that'll be completed might be different, or will be different. Thinking about even the escalation, the warning signs, step 1 might be difficult, or might be done differently, how that conversation happens. And then similarly, well, I was going to say step 6 on the keeping the environment safe, but often people will have obviously identified a particular method. But again, with method switching and so on, there's complications. So I was a long way around of saying I don't know if we know for certain, but the opposite is also true, is that there's no evidence that it doesn't work.
Yeah.
Or there's no counterindications. Yeah,
thank you. And actually, you mentioned their access to means, and we've had a couple of questions on this about, you know, how do we explore access to means? Have you got any tips on trying to get more commitment from people to remove or reduce access to means? Linda's nodding, so I'm going to come to Linda first.
I think one of the things with access to means is that, yes, I always had access, and no, I would not always tell somebody what I had and what I didn't have. But being a peer support worker, I had one lady that quite frequently overdosed, and I said to her, come on, I know what it's like. Do you have anything? And she just nodded her head, so I knew straight away she did, only because I did, and she had similar diagnosis to me. So I said to her what had worked for me, and it was putting it away in a lock container and putting the key somewhere else. So by the time you got the key to unlock it, the emotions are starting to come down, because the feelings don't last all the time. So by the time you've unlocked it, you might have then got the capacity to think of what you're doing, and to which she did. So hopefully something like that would help. I mean, you can't get rid of the means, because people have either got their secret stash, or you're going to have to clear the house out of everything that is sharp objects, or, you know, anything that you could tie around the neck. There is just no way to clear the whole house of everything, but it's trying to find a different way of dealing with whatever you've got in the way of means.
Thanks, Linda. So focus on interruption there, and the value actually as well of peer support in having that experience and being able to use it to help negotiate possibilities. Thank you. Rory, did you want to add anything to that?
The other one I'd add is trust. Obviously, it's building trust, and certainly because we did transcripts of all the safety plans in our study, and looked at or listened to a lot of the ones of how we negotiated that, and obviously it was difficult in many cases, but I think building trust was just the key. And then what was interesting is in some of the follow-up calls, there was, because I think in about 47% of our cases there was 80 people who'd attempted suicide in our study, and I think 47% updated their safety plan. Now, most of the updates were to do with the earlier steps, but there were some updates on reflection, and that relationship building with the person really helped with that building trust, and then thinking innovatively. So a lot of our people would give examples of what other people found it helpful, or other people found it helpful that if you did this, it might be helpful for your partner to look after your medication, or a friend. Or the one which we struggled with initially was obviously if it's an area of concern that somebody's going to end their life, and it's just help them think through an alternative way of getting to work or to the shops or whatever it might be. But yeah, trust, I think, would be the one thing that came time and time again. Yeah,
definitely. And the other thing that you mentioned there, which about what you know from other people find this helpful or that helpful. One of the highlights of my week is involvement with the Recovery College, where we co-facilitate a group called Taking Charge When Times Get Tough, which is essentially around embedding the principles of safety planning, and the trust within the people in that group, and the sharing that goes on is it kind of like blows us away every time. And so I suppose my question to you is, my experience tells me that a group can be a really good way to work through safety planning, to think about safety planning techniques. What's your view on that, Rory, from a research perspective?
I don't think we know. I think, yeah, for thinking through or testing out ideas and solutions, I think it's a really good idea. But my other response is, are there risks associated with that in terms of detailed discussion with other people about methods and means? So I just wonder, there was some way of how there's obviously a balance. These things are always a balance of balancing the risk and the benefits, or the potential harms. Now, I don't think there is any evidence for that, but for the harms. But that's one of my immediate thoughts. But actually, it'd be interesting to think about, because I know that when Craig Bryan he's done the brief CBT work with veterans, and one of his components is definitely group-based work. Now, I don't know whether the safety planning is part of that group-based, or his crisis response planning, as he describes it, is part of that group work. Yeah, so yeah, I think it's a number of different things come to mind.
Yeah, we're quite careful not to sort of talk about methods. It's mainly about when warning signs, triggers, and strategies, and self-efficacy in that implementation. But yeah, thank you. Linda, did you want something? Were you going to add something there?
Yeah, I'm just going to add something there. Obviously, I went through group therapy, and it was so interesting at the way we worked as peers together. But if you're doing something like that, there has to be strict boundaries, that you're not discussing ways and means. You're discussing techniques instead on preventing it.
Yeah, absolutely. So good, thank you. Right, so we've got 5 minutes. I'm going to have there's two questions I want to put to you. That still isn't all of them, but so bear in mind the time with the answers. One is, what techniques are most useful with sort of enduring suicidality?
Well, if we look again, it depends on the clinical presentation, but the evidence base, well, obviously with borderline individuals with borderline, obviously it's still DBT, but it depends on which analysis you look at the DBT evidence. So Keith Houghton's, obviously Cochrane stuff would suggest it reduces frequency, not of self-harm more broadly, and but not the number of people. But I think that I think that would be in terms of the strongest evidence base, and then it's CBT for that's. But we haven't got the evidence base isn't fine-grained enough to make beyond borderline personality disorder. I think beyond that and co-presentation of depression and anxiety, I don't think we can say anything beyond that, to be honest, because there's some obviously with psychosis. There's obviously evidence for psychosis more broadly in terms of but treatment for mental health problems more generally. But I don't think we know yet whether CBT for psychosis specifically reduces suicide attempts, for example. I don't know. So I think there's so many gaps that we definitely know that CBT works in general for reducing suicidal behaviour. And that's where I think most of the evidence, most of the studies have focused on CBT or derivatives of CBT. Mindfulness obviously has been, Mark obviously did his trial a few years ago, some evidence, but not obviously post-hoc analysis with people with trauma. Obviously there's some effect there. So the short answer is we don't know for certain if we go beyond that, but the recommendations would be, and obviously Karen and I are on the NICE guideline group for the management of self-harm, and the new guidance will be published next year. And obviously we can't say what the new guidance will say, but the current guidance obviously still recommends obviously treatment of the underlying obviously mental health problem, and then obviously the treatment for self-harm as well separately, or not separately, integrated, but you know what I mean. Yeah. What's your sense in that?
Linda?
Yeah, the therapy that I went through was a mixture of CBT, DBT and MBT. And those all seemed to work. I did have a year worth of DBT, which was a complete waste of time for me personally. It just didn't work. But having the mixture of those three actually helped.
Yeah, no, and the other thing I suppose I would add, just that's come to my head, is the other stark reality of it is that 3/4 of all suicides are by men, and we don't know whether any of these treatments we've been talking about work for men, because the studies just haven't been done, and there have been sufficient numbers of men versus women or whatever in trials to do that and those analyses. So I think I think we've so many challenges ahead, and if I hear one more time about levelling up, the levelling up agenda, well, let's do some levelling up.
Yeah, there's so much research, and the other question, which perhaps I'm not going to ask you to answer in the last minute, but I think we need a webinar on this issue. I mean, the question was, how can we truly reach a person presenting with ASD/OCD? And I think, again, there's a lack of research there, is my understanding, but it's not my area of expertise with regards to interventions such as safety planning.
Well, just say one. I can't speak about the OCD. I don't think there is anything on that, but I'm working with Jackie Rogers at Newcastle as leading a study, a feasibility trial, which we're adapting safety planning for autistic young people. So hopefully that's a start.
That's a fantastic start. Thank you. So we'll watch this space, and I think in the future we will have a webinar focusing on people with autistic spectrum disorder. Okay, so with seconds to spare, that's the end of this webinar. Rory, thank you for taking the time out of what I know is a busy day to join us. Linda, likewise, thanks very much to join us again. These are so much better with you being part of them. Thanks to everybody who joined us for your questions and for your commitment to suicide prevention. These webinars have been really well attended, and that's a testament to the commitment of you as our staff, and thank you for that and for everything you do to help us in our endeavour to reduce and prevent people dying by suicide. Thanks very much.
Sorry, those additional slides, because I had additional slides which going through if we had more time to go through the step by step, but you can just look at those in your own time if you want in addition. Okay, thank you, and thanks for the invitation.
Thanks. They'll be on the internet, the slides. Thanks very much, everyone. Bye-bye.